sodium glucose co-transporter 2 inhibitors. Are these actual miracle agents? And who are they miracle agents for? With me today to discuss this is the one and only Andrew DeCaro, who is my director of the Testosteronologists. Welcome, Andrew.
I appreciate the one and only part. I'm always thrilled to do these. So we got a really exciting one that we're going to be doing today. So
right, this is it, guys. This is the current top of the world class of biohacking, repurposed medicines, off-label, or just aggressive medical management. This class of medications, we've been on it 8 months.
about
Andrew,
that,
right?
about 8 months now, we've been using it. Oh,
Unbelievable. Look at the arms. Yeah. Guys, we live for you.
More importantly,
we show
behind me. So
look at them with a rest in peace, Hulk Hogan. And not to mention, we're going to talk about, guys, listen to this today. So we've put together a bomb of a presentation on what this drug class is, what it isn't, who it's for, what it's about, what it could do.
Yeah.
And in my opinion, in the end, stick with me, who can benefit in this class, in this subgroup of men and women on PEDs and steroids, because I'm here to protect.
It's not one you want to miss.
I'm Dr. Thomas O'Connor, a lifelong powerlifter, board-certified physician, and published academic author. I've taken care of thousands of men on testosterone and steroids, and now I use my media appearances and this YouTube channel to provide education and harm reduction. Subscribe now so I can help you stay strong and healthy.
Right. You want to understand this one. And again, this is not medical advice. I am not pill pushing. This is using technology. You know what's funny?
Go ahead.
If I took this agent, that's why it's just called an agent. It's an SGLT2 inhibitor. It's an agent. There's no name. We're going to just talk on generic terms. We're not supporting any of the companies. We're going to talk today. And if I took this agent and I package it up with its benefits, and some guru, some guy you love and trust, it's yoked, says, dude, this is a peptide, bro. You would take this thing and gobble it despite not for human protection. But the funny piece is, this is for human consumption, and we have a lot of data. So, Andrew, I want you to tell us, as you're my science guy, tell us about the sodium glucose co-transporter class mechanism, and let's just get
so in
into
order
this.
to understand what it is, we have to, where we are now, we have to understand where we come from. So the SGLT2 inhibition was actually discovered in the 1800s. Actually, these medications, SGLT2 inhibitors, actually come from a natural source. They actually come from the bark of apple trees, and there's a compound, yeah, you didn't know that. There's actually a compound called fluorizin, and this was shown to have SGLT2 inhibition. However, the problem was it came with really horrible gastrointestinal stress, and it was not able to be metabolized much in humans. So we go into the lab and we synthesize molecules that SGLT2 inhibitors that were able to be made for human consumption, that had a very strong safety profile. So, for example, you know, that came the advent of empagliflozin, canagliflozin, dapagliflozin. Anything ends in the word flozin. So how do these miracle molecules work? SGLT2 inhibitors, sodium glucose link or co-transporter 2, they work by blocking sodium glucose protein in the kidney. This protein normally helps reabsorb glucose back into the bloodstream after the kidneys filter it. By inhibiting SGLT2, these medications cause more glucose to be excreted in the urine, thus lowering blood glucose levels. This mechanism leads to increased sodium excretion and, obviously, like I said before, glucose excretion, which helps alleviate blood pressure and will improve heart health, and we'll extrapolate into that a little bit later. Doc.
Excellent. Good job. Very, very clear on that. So these mechanisms, it's working It's working primarily, we know, in the renal mechanisms in the kidney itself. And the kidney itself has a glomerulus. It's very complex, loop of Henle. It has incredible complexity. We know that its indication initially was for diabetes because you're losing your P, which is the side effect profile is going to be interesting, right? One of the side effect profile, and it was hard for me to get my head around this as a patient, as a man taking this drug. Like, I'm going to be peeing I'm going to see in my urinalysis like massive amounts of glucose, God forbid protein. Why, that was a Freudian slip.
No, it's okay, but you brought on something really interesting. How these were initially designed for type 2 diabetics, but accidentally, in the original studies, they discovered that a lot less people were developing heart failure, and we were seeing improvements in existing heart failure. So that led to the Emperor trials. Okay, and the Emperor trials, there was also then which showed the improvements, reduced hospitalizations, reduced death from cardiovascular causes, heart failure, CHF, preserved ejection fraction, CKD, which their indications were then changed to CKD, CHF, along with T2 diabetes. But keep going, Doc.
So let me break that down for
Please
everyone.
do.
That's my techno guys. I love you guys so much, and I know there's a lot of different languages here, and you have to bear with us. We are working on the app and Testosteronology, and of course here across social media to get everything transcribed into other languages. Now look, guys, this comes first out as a protector like the GLPs years ago for diabetes. And as Andrew said, because of the outcome, we're always looking at data, like, there's secondary, there's tertiary data. As we look at people that are on medicines, we see good things and bad things. Maybe we could recall medicine, or maybe we look at a medicine and say, hey, we didn't realize, like, we this thing opened up out of the box, out of the gate for diabetes, but it's really protective despite diabetes status. It protects against heart failure, not coronary artery disease. Guys, heart disease, general term, right? There's many manifestations. Classically, the coronary arteries get ischemic and blocked, hurts the heart, called a heart attack. The heart tissue itself is a muscle. When that doesn't function, it's called heart failure. Guys, I'm telling you, everything is so intimately related. You can't tease out one from the other. The number one cause of heart failure is coronary artery disease. And then it's a vicious cycle. So look, when you understand the benefits of this class from a real scientific standpoint, as Andrew said, then we're into the modern world where recently, in the last 5 years, 3 to 5 years, incredibly, because of this data, that we see protection from keeping people that have not diabetes, but have chronic kidney disease and heart failure. Now, let me go into the heart failure a little bit, which is something that's the drug of choice. If you look at heart failure, men, this is more for my men, you're on steroids, you're on testosterone, you're loving your life. If you don't understand your ABCDs and you don't understand your echo, and the basis, I'm going to break down the echo. I'm going to have a whole video on how to break down the echo. If you understand your ejection fraction and how valuable that is and how silent that is for you when you're in your 40s, 30s, of course, even younger, of course, older, there's no time to give up. If you're 70s, you should look at everything. Health is everything, quality of life. But when you're looking at these mechanisms and you understand the diastolic dysfunction potential, the relations to heart failure with preserved ejection fraction, this is the number one agent of choice. How many men that I take care of in my medical practice, that because I've looked at them in a deep microscope, I put them under the microscope, I get echocardiograms, of course, calcium scores, maybe CT angiograms, I send them to nephrology, I look at them and I find out that they have proteinuria, that they, because of the years of just being hypertensive, just hypertension. Forget testosterone and steroids. You start adding testosterone and steroids, brothers and sisters, you know what's going to happen. It's exacerbated. I'm telling you, this class of drug is an absolute. That's why I'm not giving one. Well, I'm not giving one blessing. I'm giving a blessing to the class, but there are always side effects. It's always understanding what this, and this is going to be, we're early here. Oh, there's other people doing this. And there's anti-aging movement on this. But again, and God bless them, this is educational. So let's go, Andrew. So the FDA has diabetes, it has CHF, and it has two types of CHF. Real CHF with reduced ejection fraction, and CHF with preserved ejection fraction, which I can go into later, but not today. And then chronic kidney disease. There's so many people in the world that have chronic kidney disease and they don't even know it. They don't even know it, and they're missing out on this medication. It makes me very angry. Now, let's go into the secondary mechanisms of action that's so pleiotropic and so just incredible that we're so turned on by.
So one of the things that, like when we have a medication that is so remarkable as this, that offers such robust renal protection and so much robust cardiorenal protection, and influences and improves type 2 diabetes, we often try to find what the hell is the mechanism? How is it able to do this? And so there's a number of proposed of mechanism of action, how we feel this works. So one thing is for one, we know that but when you take 10 milligrams of, say, empagliflozin, you are excreting about, on average, 60 to 100 grams more of sugar per day. Okay, and now we're talking about thermodynamics, calories in, calories out. 60 to 100 grams of sugar times 4 calories each, that would be a calorie deficit of 400 calories per day. Multiplied by 7 days a week, that is approximately 2,800 calories per week extra being lost by default without exercise. Now add a GLP-1, then you're in business. Now, what we believe here is that this plays a strong role in autophagy. It almost mimics fasting, because it also amplifies the AMPK signal, which shuts off mTOR, kind of very similar to metformin in a sense. And like rapamycin, but not as robust mTOR inhibition that rapa would have. So another proposed mechanism, especially behind the heart failure, is we have less glucose, less sodium in our bloodstream. That would mean that is proposed that now, instead of using glucose as fuel, the heart would be using ketones, which is a much more fuel efficient system. The best way to put this would be if I have in my Audi, if I were to put regular gas into it, it likely would not run as well. But if I put premium super ultra in it, it's going to be more fuel efficient.
I thought you have a Volvo.
Well, I do have a Volvo.
Okay.
Yeah, but I've had an S5, an Audi S5. Going off topic. Anyhow, so I don't even know what fuel you put in the Volvo. So that is the proposed mechanism, is that it increases the fuel mobilization becomes more efficient. So the heart's now, there's going to be an effect on the preload and the afterload. Boom. Okay. Improved preload and afterload, and now blood pressure improves. Now fuel mobilization. Bam.
Right. So let me pick it up from there. So that's the heart. Again, guys, you want to block the vector forces, right? These are my ABCDs. You want to block those vector forces. You're on testosterone. You're on some steroids. You're living the freaking dream. You don't want to have excessive oxidation, inflammation. You don't want enlarged hearts. You don't want coronary artery disease. You don't want chronic kidney disease. And it happens. It just happens with aging. And then with steroids and androgens, I'm telling you guys, there's a way to do it. There's a way really to do it, but you got to have the thinking caps on. And you can't just take all these drugs and steroids. I'm going to cover that in the end.
You don't want to be like us.
Some of the ethical standpoint, right? The ethical side of how I think it can be done, okay? And what I do, right? So, and I'm 61, and with the grace of God, whew. So look, guys, in the heart, when you look at the heart and kidney, those are babies. Those are little babies together. The cardiorenal, right? Those are my babies. Those are my babies, the cardiorenal, man. I've always known as the anabolic doc 20 years ago, with all the guys coming, all these big guys coming in, and they have early heart and kidney disease. And I meant, as an internist, I said, shit, man, that's the ABCDs. And now this is, again, I think, the top miracle agent in the world. That of course the individual agents, but this thing hits A, B, and C.
And also too, it has really strong, robust anti-inflammatory benefit, especially on the interleukins, right. Some C-reactive protein. So it really, which probably the anti-inflammatory benefit is another thing that is probably aiding into.
And you can check all this, guys. Yeah. Right. But let's so he hit the heart, right? Let me hit the kidney. So in addition, what happens in the glomerulus, what happens in your functional unit, of the kidney, right? The nephron and the glomerulus, it's so sensitive, guys, to pressures. So when you have too much pressure, blood pressure, it destroys the kidney. Fact check it. When look at people in dialysis, they're there for diabetes and hypertension. And steroid users, it exacerbates it, guys. It just takes time. And depending on your genetics, the moons line up. So this agent reduces glomerular pressure. It reduces this pre and after load. It's very similar when you look in the glomerulus. I'm telling you, it reduces proteinuria. How many of you come to me where you have silent FSGS from steroids, or even just testosterone and hypertension and NSAIDs and too much protein just by being big, which I love being big, guys. I love being big. I don't want to be small.
And by default, the testosterone, the androgens are going to increase sodium retention. And this,
right. So the RAS system. So I'm telling you guys, we've waited for months to make this video because we've been on this thing. We've been on it for months, 8 months together, and it's been out there, guys, and it is freakish. And I was able to break personal records. I'm benching close to 500, and with the grace of God, guys, I suffered through a medical emergency of bilateral pulmonary emboli in my pulmonary arteries, guys, and I got through it and walked out of the hospital because my heart is so good.
And you saw my labs on this stuff. It was like ridiculously.
You should see my labs. You should see it. I'm 61, guys. So this is my baby, and I'm telling you right here, but again, you can't just start this goddamn thing. You can't just do that.
So who would qualify?
So now, hold on. So the reduced it reduces proteinuria. I can't tell you. You have heart failure. You have preserved ejection fraction or frank heart failure. You have chronic kidney disease. This is all FDA cleared. It's even FDA cleared where the FDA is known to wait till people are dead. Waiting till you're dead to give it to you. Benefits of the blood volume. Now, again, guys, there also are side effects. Who do we think is the candidate? Andrew, let's do it. Who is the candidate? I'm going to open up. Who's the candidate? Number one, FDA. Who's the candidate? The FDA, again, guys, not for or against the FDA. I may even like this administration, right? Kennedy with Maha? Come on, guys, we're trying to make people healthy now. But I'm not going to get involved in this industry, right? I'm a doc, I'm trusted, I'm over here. But if I'm not going to hold out on you guys when I have an agent of absolute miracle proportions. Now, how are you going to get it? How are you going to afford it? That's a whole nother animal, and that's what irritates me because it's too expensive, and I think I would make changes on that from the policy period going forward, policy changes. So, right, this is generic. And empagliflozin is going generic soon. Okay, that's all we're going to say, guys. Now, look, and you have to have a great caregiver. You can get a testosteronologist. You can get your doctor, your nurse practitioner. Stay away from some of the far guru guys because, come on, guys, try to stick to the bone here and stick to some good science and some clinical people that have experience, please. Okay, now. Right, we're not. Again, I'm not. But I'm full of love these days. I'm full of love. I'm full of love. I mean, it is. I want people just to get information that's proper. This is proper trusted information, okay? It's just not out there yet, and you need to hear it. So who is the best candidate? Well, anyone who doesn't want heart disease or kidney disease early.
And CHF,
Okay.
yeah.
Number one, because how many people that when you if I do an executive physical, of course I take some patients in and oh man, imagine my history and physical, imagine my executive physical, echocardiograms, full coronary arteries. We have to get imaging of the coronary arteries and urinalysis. How many guys come in? They're peeing protein and they already have a low ejection fraction where they have preserved. I saw a guy last week. He's got full-blown diastolic dysfunction, and he's got ankle edema. This guy, that's going to be a diagnosis of heart failure with preserved ejection fraction because his EF was 53. Guys, so that's a candidate right there. You don't know you're a candidate because it's so esoteric. I want you to check yourselves with the echoes, the corner. I want you to understand your ABCDs. It's just frustrating for me because it is esoteric, and that's why we need to mobilize more educational, clinical, internal medicine, and testosteronologists. Okay, so who are we going to wrap up with? Who's my dream candidate that I think, from an ethical standpoint, that we could utilize? Who is it, Andrew? Right.
Me.
Yes, you.
Yeah.
But what are you? Who are you? What do you do?
So I am, what we call the modern anabolic male.
You are I was going to say, you are the modern anabolic male.
So, the goal is to, we want to be as strong, just your mantra, strong and healthy. I want to be as strong and healthy as possible. I want hormone optimization, and I want to keep myself protected. So how does this medication, really quick, benefit somebody who is, say, using TRT, hormones,
right?
For therapeutic purposes? One, this medication can prevent the remodeling of the cardiovascular system. Okay. Number two, it'll protect my kidneys. That we know. Number three, it will have a strong anti-inflammatory effects, and it'll help induce a state of autophagy. Because I'm reducing more calories now, but mainly the cardiovascular benefits. It helps my heart. Function more robustly. It protects it protects me from the deleterious effects of possibly CHF, et cetera, et cetera.
Right.
Yeah.
So here's what I'm going to say, Andrew. Perfect. The modern anabolic male.
Thank you.
And this is what he is. 36-year-old man. Look at him, living the dream. Every moment is quality of life. Nothing else matters. Why would you want to get older and not enjoy your androgens? We're talking about people on PEDs and androgens. This is a harm reduction call out. Yeah. So if you are on steroids, I want you to take the lowest possible. I don't want you to do. If you're a young man, I don't want you to do steroids if you understand it's going to affect your hair, your brain, and you're going to have to be on testosterone sooner or later, with all the consequences and all the nitty gritty and all the complications of fertility, problems with fertility, and things that I deal with every day. So, but if you're a robust man, you're a modern anabolic male like Andrew, and you're in your 20s or 30s, and however old you are, and you want to be on androgens and you want to be big and strong, take the lowest effective dose. Understand your ABCDs. This is a medical class. We don't have data on outcomes. We don't have data on using it as harm reduction for steroid users. We don't. But how can it not help across the board if you understand the A, B, C's, not to mention my D? This is why I'm on it for now close to a year, and I've taken my time to get on it because I don't want to take a medicine that I don't need. But how many of you want to be aggressive on your health to enjoy your quality of health?
The best defense
to
is strong
enjoy
offense.
your quality. Again, and that's just do not use this. Do not take this unless you have a good healthcare provider and you understand the side effects. But I think I am very far ahead. Andrew, we are very very, very progressive.
Far ahead in the
on this.
awareness of all this stuff, because the biggest.
This is, again, look at me, guys, with the grace of God. Again, I'm just humbled to be at the age and to be where I am with my brain and what I'm doing in life and my strength and my prowess and just everything. It's at this age, I can't tell you what it's worth to feel like this. And of course I'm on androgens, damn right. And don't do what I do. You understand what you do for yourself and the consequences. Now, let's close with the side effects. Hypovolemia is no joke. Lowering blood volume and hypotension, it's not a joke. When I initially took this medication, only 10 milligrams of this empagliflozin, my blood pressure, I was constantly, we text all day back and forth about our vital signs. You know, we compete, Andrew and I compete on our vital signs. And which is fun.
Yeah, it's true.
I'm 60-year-old man, and I'm basically competing with a 36-year-old man on vital, and he's got great genetics. Yeah. Okay, right? And I have to use drugs to compete with him, but I'm still winning. I'm just kidding. I mean, we're a neck and neck. We don't win.
It was interesting. Your blood pressure showed strong reductions. Mine didn't really move, despite
so
the telemus.
My blood pressure went down. My blood pressure went down, but over the course of about 3 months, that was a transient effect, and my blood pressure went back up, and I'm back on my regular medicines. You know, this is the ARB, right, that we were on.
Testosterone, Anabolic, et cetera.
And the Bevel, I don't want to really go into those. So the ABCs, those are the medicines, and we have to be so careful to add another medication into the mix. But we added this as our pillar. It's our last pillar, we said. And maybe there'll be another, but no, I don't think there'll be another one for a while. Now, side effects, blood pressure, again, hypotension, volume issues. If you have heart or kidney disease, I can't tell you how this is, be very careful. So you just don't gobble this stuff. And if you're 23 years old, I don't think it should be. I don't know when the age is. You know, mid-30s, you're on testosterone or steroids, you're living the dream, your vital signs are you're not perfect at all. Why wouldn't you keep your vital signs perfect, protect your heart and your kidney? Huh? That's just my guy. That's my guy. My guess is there's tens of millions of you guys out there. Again, but you better have the resources and the understanding of what to monitor. Now, and the other rare side effect is ketoacidosis and urinary tract infections. Tell us why, Andrew.
So, bacteria loves glucose. So when you're peeing all that out, all that extra glucose is going out there too. Glucose bacteria, it's like a festering ground that can cause UTIs, infections.
Right. So the data showed it's minimal. It's minimal that, and I believe the really severe fungal infections that were, and even Fournier's, even like dangerous, like deadly bacterial infections that can secondarily come in relationship to mycoid and to fungal infections. This is ICU and surgical stuff here. It's they have to say it. It's very rare, but it's because I think it's probably going to be a debilitated elderly patient, say a man or a woman who's in a diaper in a nursing home and doesn't have very good hygiene. Matter of fact, I know that's because if you're ambulatory and you're peeing and you're not peeing into your underwear and you have very good hygiene, and Andrew and I came up with some, again, this is not medical advice. So we're concerned for the side effects of your peeing glucose. You're peeing glucose in your urine. I mean, glucose is going into your urine, right? So again, is it a breeding ground for bacteria, not to mention fungal infections when you're looking at jock itch and things like that? And urinary tract infections. Guys, if you have BPH and you have a history of this stuff with a large prostate and you're my age, younger or older, and you have a history of UTIs, this may not be a good drug for you. This may be contraindicated. You have to do it yourself. That's why you need to come on Testosteronology on the app. It's the only digital place in the world where you basically do it yourself as much as I can to help you guys. So you can stay clean. You could use cranberry juice. I'm not going to be funny with you guys, but I spray a couple times a week antifungal, which is like for jock itch. in my perineum, under that region where the jock itch would be. Voila. That's what I do. And I hydrate myself more than ever. And I can't tell you guys the benefit. I look up, I take my medicines, I take my agents, right? Not medicine, it's not medicine, it's an agent. It's a repurposed agent, guys. It's a repurposed agent for you. And we're modern. But is it for you? It's for you. Is it for you? You make your decision with your fingerprint and with your own healthcare providers
100%.
and your family. Thank you so much, Andrew.
Thank you. Hope you guys all benefit from this.
Give us some great comments, guys. Are you on this? What do you think about this? Do your research. Really understand this. You're going to see this is the future. It's here today.
Questions, comments, even sarcastic remarks, we accept it all.
Yeah. Well, try to keep it clean,
Fair
guys.
enough.
We're trying to really get this channel. I'm trying to bring so much education and love and support, because at my age, guys, and after the fact that I almost died from a pulmonary embolism, I can't tell you, it's emotional, guys. It means a lot to me to share my innards. I could hide all this stuff if I wanted to. I could have easily hid this stuff. And there'll be backlashes from this, because some people looks like I'm pushing big pharma. F off. I'm pushing for you because I use these agents. And I'll leave you on this, guys. I will take the kitchen sink. I will rip it off the wall with a chisel. I will grind it up into a grinder. I will liquefy it and inject it into my ass, the kitchen sink, if it allows me to live the best quality of life for as long as I can. God bless you guys. Thank you so much, everyone.